Good evening, friends. I am Dr. Ankit Bansal from Jaipur. Today, we all have gathered here on a very interesting webinar conducted by the Chess Council of India to have an important interaction on a disease process which has made his news in the recent time. I would like to congratulate our Chess Council of India team to always think beforehand for an important disease entities at their outset, be it COVID and its various aspects, which made the clinicians and healthcare workers aware for its important leads in the diagnosis and management from time to time. Friends, possibly we are facing one more of these kind, an influenza outbreak. This time it's H3N2. So friends, we, along with the esteemed panelists from different parts of the country, will be discussing today on the various aspects of this virus H3N2, maybe a new strain of an old flu, discussing the various entities related to it and how to combat its challenges among the healthcare workers, and so that we can combat this challenge of H3N2. Dear friends, before moving forward, have a brief glimpse of this new virus, or maybe appropriately called a new strain of an old flu, that is the influenza A H3N2. Now, we could frequently see these news in the last decades because as the first outbreak of pandemic in 2009, maybe this could be the headlines of the various newspapers. But now it is again threatening into 2023 with H3N2. And in the last month, we have seen frequent of those making the headlines of the newspaper and the various media channels. Now, if we classify influenza virus as type A and B, type A means seasonal, avian, swine influenza. As type B as a seasonal influenza, type A causes significant diseases. Type B is mostly restricted to the milder disease, but may cause an higher severe disease also. Type A, as we know, that can cause infection to humans and other species. Type B is mostly limited to humans. Type A can cause mostly epidemic and pandemics, and type B generally cause a milder epidemics. Now, if we go by the history of influenza, there are certain milestones that we need to remember. It is way back from 1917 to 2009, which the current pandemic of H1N1 stands. In 1917, the US enters the World War first. In 1918, there was a outbreak of a flu. The spring and the full waves of influenza were there, and that reduced the life expectancy of their people. Now, in 1957, the type of virus changed, and it becomes H2N2 flu virus, and it emerged a trigger for a pandemic, and that replaced the 1918 influenza pandemic virus. Now, 1968 was another year that was an important one, where it caused an H3N2 virus emerges to trigger a pandemic that replaced the H2N2 pandemic. 2005, there was genomic sequencing of this virus. Yes, the importance of vaccine was understood, particularly in those patients who are high risk of getting this disease way back in 1960. What the current pandemic we have been dealing, it is 2009, with mostly of H1N1 virus. We can say that this 20th century was seen many pandemics, but have taken millions of people, and they has caused the death of those people. It could be a Spanish flu in 1918, 1 to 4 million deaths in 1957 and 1968 with the other various strains. Currently, 2009 pandemic started with the H1N1 virus. Now, if we consider what were the prerequisite for a pandemic influenza, there are certain things that has to be remembered. A new influenza virus emerges to which the general population has little or no immunity. New virus must be able to replicate in humans and cause diseases. And the new virus must be efficiently transmitted from one human to another. That possibly cause or define pandemic. This is the vague picture of how your H3N2 look like. As you could say that there is a nuclear material and there are surface material which include neuraminidase and a hemagglutinin and the various classification of its name, which includes the virus type, geographic region, strain number, year of isolation, and virus subtype. So there has been a resortment process which happens into swine, in birds and humans, and ultimately it causes a pandemic influenza virus. I think it would be correct to say that we are currently into an COVID era. What these 3 years has taught us, maybe we have been listening a lot from so many years, but these 3 years has taught us many things. Possibly the definition of pandemic, and in which we were of the highest rating during the COVID era. That is, we know that it goes from one phase to the another phase. So we learned what about the COVID pandemic can cause. Similarly, we are aware of these type of droplet infections because why it is troublesome? Possibly because it can be transmitted from one person to another in a very easy way. May it could be COVID, may it could be the influenza virus. We know method of diagnosis. We have learned a lot. There are few things which has been very common these 3 years. Yes, the diagnosis process nearly remains the same. Yes, COVID, which hunted, which searched a lot for the possible therapies. Since some are there, some in progress, but no defined way. But from last 2009 influenza pandemic, there have been basket for certain medications which could help out in these kind of diseases, but it was for H1N1. Now, these are the things that we learned a lot in last 3 years. I think most of us will be aware about all those stuff. Maybe the personal protection equipments, hand hygienes, like the waste management, these all stood tall for the prevention and isolation precautions of influenza virus also. So there is a whole list of entity related to that. The most important part, yes, we have learned about COVID pandemic also, vaccination. Similarly, for the influenza also, there is an important aspect, which is vaccination. So that is an important part that has to be discussed upon during our panel discussion tonight. So with all these stuff, I know you all may be having lots and lots of questions related to the current strain, that is H3N1. Is it different from the previous strain of H1N1? Is it different from COVID? How to go about it? What are the signs and symptoms? What is the method of diagnosis? What could be the possible treatment line? What could be the prevention factors? And is there any role of vaccines? Possibly there could be lots and lots of questions that are rising in your mind. So friends, come along with me in this an important webinar conducted by Chess Council of India with our esteemed panelists to discuss on a very important issue on this new entity of virus, that is H3N2. Is it a new strain of old flu? So dear friends, we have a group of our esteemed panelists with us to discuss this important aspect. We have Dr. Sujeet Rajan. He is a very reputed and eminent pulmonologist of the country from Mumbai. We have Dr. Tridib Chatterji. He is a very senior, enthusiastic, inquisitive pulmonologist from Mumbai. We have a very young and dynamic pulmonologist, Dr. Kripesh Ranjan Sarmah from Guwahati. we have a very talented pulmonologist, Dr. Tanushree Gehlot from Noida, and we have a very elite pulmonologist, Dr. P Arjun from Trivandrum. So, friends, let's start. So, I start with Dr. Sujeet. Sir, what is the history of influenza pandemic? It has been 100 years now, as we can easily see. And the current pandemic, we are supposed from 2009. So what is the current status of this present pandemic?
Thanks, Ankit. So I have to first, I think, confess, just like CCI has a disclaimer, that I'm not a very, I would say, proficient virologist or epidemiologist, but I have been reading, and I think the current state of the pandemic is definitely on the wane. We are seeing far more negative tests, and we have seen flu pandemics, Ankit, right from, I think, the 16th century. If you look at the history of pandemics, there's a book in 1920 that has described 5 flu pandemics before the 1859 pandemic. And then you had, of course, 1958, where it was an H3N2 strain, and then the 1967-68, which was the first time H3N2 as a virus was isolated. And then the vaccine started getting manufactured. So it's been a long journey, and I think the current state of the pandemic is such that we are seeing a lot of vaccinated people. We are seeing good herd immunity, I think, to COVID-19 infection. But we are seeing a resurgence of seasonal influenza, and this was probably expected to come. So if I had to kick off on the first question you've asked me, I think one of the highlights of the current pandemic is that with the decreasing numbers of seasonal influenza that we saw in 2020 till 2022, and that was a really low numbers. I mean, we're looking at like a few hundred cases per week in many regions of the world. I think now that is resurging, and obviously there are reasons why some people are suffering more, and I think especially children. And my experience has been colleagues in pediatrics are seeing quite severe cases in children now who probably never suffered seasonal influenza in 2020, on 2021, 22. And now without that antigenic imprint, as they call it, are really hit hard. So that's where we're seeing it. Of course, elderly, immunocompromised would always suffer. But in general, we are seeing pockets in the country which are having a lot of flu. And we are in the middle of a flu season. And we're almost always in the middle of a flu season in India, to be honest. In the more continental parts of the country, its winter is just getting over, and it's getting humid in coastal areas like where I live. And so we are going to see seasonal outbreaks now. And so since the 2009 pandemic, H1N1, I think we've been seeing multiple seasonal outbreaks, let me put it that way, with increasing H3N2 being isolated. No one ever talked about it, actually. And the reason no one ever talked about it was that it was just considered an influenza type A virus. But the mortality and the hospitalizations due to H3N2 were almost double that of H1N1. And now we are seeing that trend in India with increasing vaccination now, especially to COVID, and influenza uptake slowly going up because of that. I think we are understanding the genetics of our viruses better. And so we're probably going to get better at understanding. Otherwise, data from India was much more sparse than other parts of the world. Even Mongolia and Laos had better data. Vietnam had better data than India. But now we're getting there, and probably even better.
Okay. So definitely it is a very long influenza pandemic, but yes, it is possibly changing its entity from the preceding years. Correctly said, sir. So, Dr. Tridib, which strain is currently dominant, and what are the statistics that we have been seeing from the different part of the country in recent months or so?
Thank you. First and foremost, thanks to CCI. And as you have earlier said, I think Dr. Krishna and the entire team deserve a Wonderful round of applause for thinking on the spot. We had a conference just 2 days ago, and something which is so viral, and now a couple of deaths have occurred. And so, first is, I think I should publicly acknowledge the thought by the CCI team headed by Dr. Kripesh. Okay, now coming back to the question. So, as Sujeet just mentioned, this flu has always been, even in developed countries. I mean, there is a literature which is as late as 25th of January 23, which shows 3 to 5 million cases of SARI, that is the acute syndrome of acute respiratory illness, by various viruses. There are 3 to 5 million cases in developed countries, of which about between 3 lakh to 7 lakh people died. And even in these countries, there are people who are not that affluent. They are on a little bit of the lower side. So there were 35% people of them were in this. So this, this kind of influenza, not necessarily H3N2, but influenza A, which, as you rightly said, is probably the main one, less to some extent B. C, D, of course, are probably not important. But they always have been there. And typically, as Sujeet clearly mentioned, in the younger age group, especially in developing countries, it's majority in the pediatric age group, whom we don't treat. But then if you talk to them, they are probably not even immunized. So they are the ones who get maximum, and those ones above 60, 65. But there were some seasons which were, cut off. The July to September is a sort of a season for influenza, and September, in Dr. Parvez Kaur and all that, in the Srinagar, the other parts, he has shown that his peak seasons in that part were in the winter months. But now we are having a little bit things which are happening even now. So that is where, again, the data isn't very much there for India. But ICMR has done some survey, and that is what I would like to read out. This survey and this statistics is dated just toward the later part of January, and they have found that the majority of cases admitted with SARI are almost invariably, about 50% of them, they have been proved to be H3N2. They have tested and proved to be H3N2. In fact, today, Dr. Krishna sent up a message. They have detected in this few days 26 cases of H3N2, 10 cases of influenza B, and 69 cases of adenovirus. And ICMR has also further specified that 92% of these hospitalized cases had H3N2, 92% of that had fever, 27% had dyspnea, 16% had wheeze, 16% showed clinical involvement of lung, actual pneumonia, 6% had seizures, 10% required oxygen, and 7% required ICU. So this is what has happened from the H1N1, which, as you know, from 2009, we discussed, was present. So this is probably because of the antigenic drift which could have occurred, and hence this H3N2 has come up. Again, probably it might not have been covered by the earlier vaccines. So that's why this H3N2 has become the maximum strain now. But it doesn't mean that H1N1 and hepatitis B has gone. I was speaking with Dr. Camellia a few days ago, and she said she's also getting a large number of influenza B also. So H3N2, but however, at least I got 2 cases yesterday. So they are. It is pretty much on the cards, which you must think of it as major.
Yes, I totally agree with you. So the influenza A is the predominant type, and in that strain, as correctly said, and what the ICMR data show, that particularly H3N2 is a predominant strain that we are currently finding out in our clinical practice and the patient with the symptoms. Now, the next thing is Dr. Tanushree, ma'am. An important question is that I know most of the patient, it could be just a flu, a cough, and a common cold, but you could have some severe disease also. So what are those population subset which are vulnerable for these type of severe diseases?
Thank you, Dr. Ankit, for putting up this wonderful question, because many of our audiences are also on the lookout of the fact they want to segregate a particular group so that they can zero in on that patient, because we are having flu in a lot of numbers, but not everyone is there to scare about. So as we all know that the higher risk age groups are mostly the extremes, like the less than 2 years ones and the more than 65 years one. But as Sujeet sir has also said that the current population of the children, even above 2 years of age, do not have antigenic imprints because of the non-exposure for almost like 2 years of COVID. They have like immunologically, you can say, a disadvantage of not being able to fight these flu on an active basis. Besides that, you also have a lot of patients who are immunocompromised. From the point of view, they might be having chronic immunoglobulopathies and chronic cancers, and even heart disease and chronic lung disease patients are also the ones which have deficient immune response towards any infection, be it flu or any other. So our categorization of these patients should be particularly on those having chronic diseases, like in lung cases, COPD and cystic fibrosis kind of patients, CHF and congestive heart failure and the chronic artery disease patients, as well as high BMI patient. Because in 2009, I remember when I was posted there in the H1N1 ward, I used to see a lot of heavyweight patients with high EMI of around 40. They were very prone. Even in COVID also, we saw a lot of high BMI patients were there. And patients of stroke, the nursing home patients, as we all know, they are in chronic facility, and pregnant females, they are also one of the very crucial category of patient that you need to zero in and get them vaccinated, or they should be on your radar when they present to you. Even currently in my OPD, what I'm seeing is even young patients of around 35, 40 age group, they have presented with lung involvement. I'll say, because I was going through an article in CDC, it was saying that these patients have hyperimmune response sometimes.
Okay.
So their response to a particular flu is sometimes hyperimmune. So that could also land them up into a hyper reactivity towards flu. So basically, the categorization of patient is important. You should be following their particular signs and symptoms. Are they having relapsing fever, or they are having cardiovascular compromises also occurring in this particular flu that I'm seeing, that the cardiovascular involvement is huge. So I know there's a very bothering cough, but certain red flags you should be giving to the patient, whether they belong to a high risk category or not. Even the healthcare workers, they are also repeatedly exposed to COVID, then different flus. So we need to have a keen eye on the high risk factors as well as the symptoms that are escalating in a way, so that whole pool of patient are the ones you need to look out for.
So an important question just arises from the mind that you just spoke about, that the younger children are more vulnerable. So are they getting the severe disease also? Because as you rightly said, possibly they are not exposed so much from last 2 to 3 years for COVID. So what in the news, in the headlines, we are seeing that they are getting the severe disease also. That could be the reason for it?
Yeah, pediatricians are generally the ones who are, alerting us a lot that the pediatric OPD is going full. And not only the fullness of the OPD, is the severity of the disease also. Many of them are landing in proper bronchodilator therapy, which had no history at all. And we are bound to give some of them even steroids and all, because such kind of illnesses we do not used to see in children. They were usually self-limiting. Even in COVID, we saw many of them had self-limiting disease. But right now, what we are seeing in this era is that the pediatric population is undergoing complicated ear infections in otitis media and all. The things are complicating that side. So somewhere or the other, I feel that they were not exposed to this usual viral episode that we usually used to have. So that is taking toll on them, definitely.
So if we summarize, yes, sir,
just one small point of what she mentioned. Some of the people are presenting with diarrhea also. I just talked to some pediatricians. In addition, they're getting diarrhea. This I thought I added at this.
We will, yes, definitely. So if we look through, possibly, as rightly said by Dr. Tanushree, the extremes of age are very likely to be infected with this virus, along with any kind of immunocompromised condition. Yes, obesity is the one important factor that she told that it could be a contributing one for getting the illness and the severity of the disease. Now, my next question goes to Dr. Kripesh. Last 3 years, we are more tuned with certain guidelines. Maybe the guidelines was changing every day or every 15 days. There are different state-wise guidelines for COVID. There was some recommendations from ICMR, anything. But do you find any standardized guidelines from the government of India or the ICMR, which has been there for dealing H3N2?
Yeah, thank you, Dr. Ankit. This is a very important question because guidelines are always helpful to guide the physician to deal with this pandemic. So, till now, there is no specific guidelines regarding H3N2. There are already existing guidelines in general for influenza from Government of India, and there are certain recommendations for the expert panels. So far as I have got information, but government has not really guideline regarding this current flu.
Okay, I totally agree with you. Suppose if it go in a very more people will be involved in this particular illness, maybe there could be some standardized guidelines from the government of India or some recommendations from the ICMR in the near future. Now, a very important thing next is any patient present you with some symptoms. Now, it is very confusing in the current scenario. What we are dealing with, influenza, is it COVID, COVID-like illness, seasonal influenza? So my next question to Dr. P Arjun, that what are the symptoms that you commonly encountered in this influenza? Are you seeing any difference of symptoms in this particularly H3N2? And how could you differentiate between the influenza symptoms, the COVID-like illness, or the seasonal flu?
Thank you, Ankit. Let me thank CCI and congratulate Dr. Krishna for having taken up this very important topic for discussion today, as we are in the midst of this sort of an epidemic. So the question is, how do you differentiate in seasonal influenza, H3N2, and COVID and COVID-like illness? So basically, let us see what are the symptoms of seasonal influenza like. It typically has a very abrupt onset. Starts with fever, myalgia, malaise, headache, body ache, sore throat, rhinitis. These are the very typical symptoms. Patients usually also have a dry, non-productive cough as well. So when we talk about this variant influenza, as the H3N2 is called, the symptoms are exactly the same as that of seasonal influenza. Some of these patients with influenza can have rashes also at presentation, though it's extremely rare. We should also keep in mind that at the extremes of age, that is very young children and elderly people, fever may not be present. They can have all the other symptoms, but because fever is not there, you should not exclude them as not having an influenza-like illness. So these are the symptoms of seasonal influenza, and that is the same for the variant H3N2 as well. Now the question is, how do you differentiate this from COVID? So basically, when we look at the symptoms that patients with COVID typically have, they have almost all the same symptoms as we have in seasonal influenza. Perhaps the only difference is that you may not have rhinitis. That is very classically present in influenza and influenza in all the strains of influenza, be it H1N1, H3N2. And the other thing which was strikingly present in COVID, anosmia, is usually not present in these influenza illness. So this is how basically you differentiate from these from a clinical point of view. The symptoms, these are the same symptoms that we see. These were the same symptoms that we have been seeing in the previous outbreaks of influenza H1N1 in the past as well. I would also like to add a small point here. That's something which all of us should know, especially the practicing physicians in the periphery. You have sometimes common cold, which is caused by something like a rhinovirus. So how do you differentiate this from influenza? The common cold basically has only sneezing and stuffy nose. Even if at all cough is there, it's very mild. No fever, no malaise, no myalgia, no headache. So this is how we differentiate common cold. This becomes important when we decide whether we're going to treat these patients with an antiviral agent like oseltamivir or not. So this, in short, sums up all the symptoms. Ankit, I'd also like to add one more point to the question which you asked, Tridib Chatterji, sir. We have
Yes.
actually done a study in Trivandrum, looking at the peaks when the outbreaks of influenza in Trivandrum. As Sujeet said, this again is a coastal place like Mumbai, so the humidity is high. Sometimes in November to December, the climate and the temperature also falls down. We have found that in 3 consecutive years, 2017, 18, and 19, we have had 2 outbreaks of influenza every year. The first one coincides with the monsoon, June, July. And the second one coincides with the onset of winter, November, December, January, and February. Thank you.
Okay. So, Dr. Sujeet, sir, your take on the sign and symptom. Are you finding any new sign and symptoms, particularly with the current strain?
Not really, Ankit. I think it's pretty much how seasonal influenza has been. The concern is always, of course, when it affects the lung. I think that's what we need to watch out for. Otherwise, our strategy to treat these patients, I mean, you have to use a lot of common sense, I think, and I always felt in COVID there was a lack of common sense in the beginning, and
Agree, sir.
there were more errors of commission than omission, as we all know. And I think just sitting back, seeing the patient, looking at the background, as Tanushree rightly said, what is your host like? If the host if it's a compromised host in any way, whether it's uncontrolled diabetes, sometimes even just severe stress, these type of patients seem to suffer the consequences of influenza much more. And then look at, of course, involvement of the lung and be early in terms of good supportive care, and if necessary, steroids in some patients, systemic steroids. So you have to be careful here. And I think just in terms of symptoms, I agree with Arjun. Anosmia is definitely not seen in seasonal influenza as commonly as it was seen in COVID. But otherwise, the symptoms could be very, very similar. I think barring that symptom, and in H3N2, of course, rhinitis is very common. Very hard to differentiate from common cold sometimes.
Yes.
I know Arjun mentioned body ache, but you can get body ache with allergic rhinitis also. So, you have to, it's you have to balance that nasal steroid with the fact that it's flu. And when the patient or the parent asks you, does my child suffer from flu or is it allergy? Sometimes we just don't know, and we got to be honest about it, and doing tests. And I think you'll probably come to tests. We did discuss that also before the meeting. The one thing is finding out whether it's influenza A or B, but then you get so many false positives on these biofires that I'm getting a bit irritable now, because you get these bacteria coming up and then we send it for culture and there's nothing growing.
Yes.
The CBC normal in patients who can afford a CBC procalcitone and everything comes in normal. So, it's a false positive. You have to be careful with PCRs and use them judiciously as well.
Totally agree. So,
Ankit, can I add to
sure,
this slight change? I agree with Tanushree. This persistent of cough is little more than what I think.
Simply the prolonged cough.
The cough is persisting, and in fact, the patient is never asthma or anything, and they actually have wheeze. There is an actual wheeze. You were ausculted. There is a polyphony. Yeah, I mean, you kind of have to give inhalers at times, and
sometimes they present the only symptoms, that is the prolonged cough. Maybe he could have some.
So that is, I don't know. They might have received hundreds of courses of antibiotics, 4 or 5 courses unnecessary, of course. So that I thought is a slightly different than the previous. I thought that coughing part.
So, considering the emotional dent that COVID has given from last 3 years, it is always important to differentiate between a seasonal flu, COVID-like illness, or influenza 1. And this differentiation possibly will help us to guide the treatment. So that is an important one. Keep allergic rhinitis as important symptoms, particularly in the influenza 1. That is important. So again, now Tridib sir, coming to a very important question. Now a patient presented with you with the symptoms. Now the questions come: what to investigate and how to go ahead.
Frankly, if you ask me, Ankit, the investigation degree or extent, it depends on the patient's pocket. That yes, I think, let me be very frank here. Maybe you'll do a CBC, that and an X-ray chest, that I think you would do. And if there is no WBC count high, then okay, supposedly more of relative lymphocytosis, but I haven't really seen that very much. It is described. You might suspect it's viral. Now, whether you will go to or do any viral testing. Now, BioFire is, of course, the most expensive. But even if you do a simple nasal swab or throat swab, and you do, I mean, I would not do only H1N1. I would do the spectrum of H1N1 as well as H3N2, and sometimes now even COVID is added. So that is costing in Bombay around 5,500. So everybody can't afford this amount. So this becomes a little dicey here, how much you can do. But yes, if the patient is a little toxic and parents are willing, then you can go ahead with not necessarily BioFire. You can do just a nasal swab or throat swab. Or if the patient gives the sputum, you can send that for the rapid molecular assay by the multiplex RT-PCR. That is, compared to BioFire, much cheaper. It is, there are no bacteria coming in that, unlike BioFire where you get a lot of bacteria are also coming in. You won't get any adenovirus, RSP. Those viruses will not be identified yet because there is some substantial amount of adenovirus. For that case, you will have to do a BioFire. But then that is nearly 3 times the pricing of this. And as Sujeet clearly mentioned, there I am also sometimes very unhappy with the BioFire. Not only the upper respiratory panel, but even the lower respiratory. When actually a bronchoscopic sample you send, and you then finally culture doesn't grow, so you are confused. And patient has spent 15,000 odd. But yes, in certain select cases, you would definitely like to do like I did in both my cases yesterday, because one was 90 years and one was almost the same age. So I convinced them, and they were willing to spend that 5,000-6,000, and we got it. The report comes in 5,000 to 6,000, unlike BioFire, which comes only in 1 hour. So that is the only, it comes a little delayed, but you can do it. And now at least today's trend, I would not do only H1N1. I would do the, because there is not much price.
Whole influenza panel possibly.
I would do the influenza panel. People call it by different names. Blue panel, this panel, that panel, the open PCR panel. So many names are given to it. So that is what my opinion is. And that's it. That's basically
what we learned. Basically, again, the tests are important, but it depends on the patient's pocket, how much he want to invest and how much he is very keen on knowing the disease process. That is also important. The clinical judgment is very important.
Because the treatment is cheaper, so sometimes...
Yes, that is the thing that they want to know, that the treatment is cheaper than that. But it's better to take a 5-day course than to go ahead with the test. So I can understand the challenge that we are facing. So, Dr. Arjun, again, a very important aspect, the first phase of COVID, maybe the first wave, lots of speculations that COVID can transmit through fomites or no, lots and lots of theories, and possibly lots of theories have been performed at our own home in the first phase of COVID. Is it stand same for influenza? Any non-living object or fomite chance of transmission?
When we talk about transmission of influenza, basically we talk of 2 things. One is a direct transmission, which is the most common one, which is a respiratory droplet transmission. And these droplets can be large droplets or small droplets. So the basic concept of this social distancing of 6 feet is basically because of these large droplets. So when the contact susceptible person is very near the source and large droplets are produced when the person coughs or sneezes, then the direct transmission happens. Airborne transmission is also described in influenza when small particles stay in the ambient environment. Having said that, fomite transmission has also been well described in influenza. So when a person touches a surface that has been contaminated by the virus and then inadvertently touches his face or eyes, he actually gets fomite transmission of the disease. So that has been well described, in fact, in influenza in the past, both in the H1N1 pandemics as well.
Totally agree. So yes, there is a theory of fomite transmission that needs to be taken care of. We have been seeing this through 2009 pandemic. So it's stands same for this virus entity also. So Dr. Kripesh, where we stand the period of infectivity of H3N2? An infected person can spread the virus till what time? What would be the duration in that?
Yes, this again, infectivity period is important because this period when the person take proper care, then they can prevent spread of virus to other people also. So usually we have an incubation period around 7 days, and then patient can can spread the viruses 24 hours before starting the symptom, and up to 5 days. This is the period where the infectivity period is for this influenza virus.
Okay. So correctly said that this is the period in which we have to, the patient and the other has to be careful if they are encountering the patient related to that. Now, again, the same things, I come to you, Dr. Kripesh. If a patient is having symptoms related to influenza, what are the danger signs or symptoms that can alert that patient need hospitalization, maybe in ICU care?
Yes, definitely. So we have to monitor the patient. So there are mild, moderate, and severity of the symptoms will be there. So if the patient is having symptoms like your breathing difficulties or chest tightness or a severe cough, or where patient is having a dizziness or this persistent vomiting, or patient when initially became symptomatic, then become better, and again their symptom has started with cough and fever. So these are the things where this patient might require hospitalization. And secondly, we have to be in a high risk group. Again, we have to be more vigilant when the very elderly patient above 65 or a very young patient, again patient having a chronic respiratory diseases, where again we have to be a little more cautious. And if the patient is hypoxic or if the tachypneic is there, these are the when oxygen saturation start declining. So these are the group of patients where these are the warning sign basically, and where this patient need to be hospitalized and need a close monitoring.
Yes, definitely, I agree with you, because the identification of the symptoms is very important. If these danger signs or alert signals are there, definitely patient need hospitalization, and this has to be recognized. That is very important thing. Now, Dr. Tanushree, we are coming to the most important prospect. We have been searching certain medical management for COVID in the last 3 years, but not sure what exactly worked. But are there definitive management options for these patients with H3N2 virus entity? What is the role of antivirals? Are they available in India? And what are the frequent antivirals that could be prescribed?
Dr. Ankit, I would just like to take a few seconds to add on to Dr. Tridib. His question was regarding the investigation part. I agree that there are a lot of panel tests available for the RT-PCR and all, but my basic monitoring of my patient at my OPD level is with the CBC and CRP, just like we used to monitor with the COVID also. The CRP increasing levels and the procalcitonin in subsequent secondary phases to rule out between the secondary infection and the primary viral is what is basically guiding me to rule out whether this particular patient is entering the bad phase of flu or not. And I think I hardly had got any of the RT-PCR done in any of my patients for now, because they are way too expensive and the TAT is very high. So it's better to go for the clinical judgment, rule out the main patients who might go into the distress part. And CBC CRP is something that is very easily available, and it's very good guide to tell you whether this particular patient is going into a secondary phase, which is serious one. Coming on to the main question, the basic management has been very well explained by Dr. Kripesh, that we need to start with the mild part. Categories were formulated in like last flu epidemic of category A and category B by the government of India. Right now, they have not been issued, but that's how we differentiate between them, and the symptomatic treatment is required at that stage. The only the category B, which is going into the high risk one, that is getting very high fever or cardiovascular compromise, or any patient like children, pregnant, you feel that the particular patient is requiring, you can start off with the neuraminidase inhibitor The most common one available being oseltamivir. Coming on to these antivirals, mainly there are two categories. Rather, a third one has also entered in. The earlier ones are amantadine and nimantadine. They are basically M2 ion channel inhibitors. But due to very high incidence of resistance, these are practically out of picture. The second group, which is neuraminidase inhibitor, is the one which is actively inhibiting the viral neuraminidase enzyme. Hence, it is active against both group of viruses, group A and B. And the most commonly available and used in our country is oseltamivir, which is commonly available as a name of Tamiflu or anti-flu. And two other neuraminidase that are probably available in our country, though I was not able to find them very easily around. But yes, there were certain sites and pharmacy which were listing these medication were inhaled zanamivir by the name of Relenza, and injectable piramavir, which is Rapivab. So both of them were available at the certain pharmacy level, not very commonly used. I don't think any one of us in the panel has also even used them, but they are available in certain cases which are not tolerated by the oseltamivir, or the oseltamivir is no more acting on them. The other one which we were discussing with Dr. Chatterji also is Baloxavir. It was recently approved in 2018 by the FDA, but it is not available in our country, and it acts as a different pathway of cap-dependent endonuclease inhibition, which is acting on the viral replication. So basically, these drugs are the licensed, approved by US FDA in 2022 and 23. But in our country, only actively used in the management is oseltamivir. As we commonly know that the starting dose of adult oseltamivir is around 75 mg/d, which you can give up to 150 mg/d in the complicated lung involvement cases. And even a child above 3 months of age can be started off with oseltamivir, depending on their weight per kg. And accordingly, there is a flow chart of increasing dosages. The only contradiction being the intolerability gastritis wise, and the renal impairment modulates the dose of the patient, and otherwise a well tolerated dose. Recently, even there have been inhibition in using as a prophylaxis, because oseltamivir is also entering into quite a lot of resistance in our population, and overuse and unnecessary use of oseltamivir should be avoided. So only your clinical judgment and the patient who is actually requiring oseltamivir should be advised, because as you know, the viruses are like mutating hell lot of times. So does the drug resistance also come in. That is important, that the restricted drug that is available should be used very precisely and practically in the patient which require it. And it is available in IV formulation also, and oral formulation also. So can be given to the patient accordingly.
Yes, I totally agree. And I come to Dr. Sujeet sir also on his take on the available options of medications. Along with, sir, there was a theory between early treatment versus late treatment. So where we keep oseltamivir into that, does the early treatment identification of the symptom or the early treatment with oseltamivir really helps?
See, if it's H1N1, it will help, Ankit. But you need to know if it's H1N1, right? We know that it doesn't work for H3N2, and it doesn't work for COVID. So in such a situation, randomly giving everyone oseltamivir doesn't make sense to me. However, if someone comes in really acutely into the ICU or into the ward with severe symptoms of seasonal influenza, I think it's justified to give oseltamivir there for sure, and probably even double the dose if they're heading to the ICU. Having said that, the evidence to give other drugs empirically is not much. Zanamivir is a very good drug, what Tanushree was talking about. In fact, I had used that drug when it was available in India, and I think it makes a lot of sense also. It's an inhaled drug. It goes to the respiratory tract where it's supposed to, where the virus is supposed to be there. So we wish we had more inhaled antivirals actually. And I think if that was there, I think it would also boost airway disease patients from using inhalers more regularly, and take away a lot of stigma with inhalers. But having said that, I think zanamivir, oseltamivir, very good drugs for H1N1. As far as the other drugs are concerned, I think we don't have a great drug for H3N2. Amantadine was used in the 60s. The only benefit, I think, of all that use was they found out a Parkinson's patient who responded, and so they realized it's a good drug for Parkinson's and took it off for seasonal influenza. That leaves us really with COVID, where we have, I think, two very good drugs, one which is not available in India, and molnupiravir, which is pretty good. Again, duration, or when do you start? Within 48 hours of symptoms is the best. So you'll see a lot of medical and healthcare professionals understanding that and being pretty fast on the uptake when they get viral infections. I think that message needs to go out to the public. You can't easily stock these drugs at home. Molnupiravir is strictly prescription based. So too oseltamivir, I believe. And so the good antibiotics to keep if patients are at high risk traveling and would like to take something for flu if they get it. So we do add it to a travel list along with azithromycin. But when and how to use it should be judicious, rather than just give everything.
Yes, I totally agree with you, because that is important, that which drug has to be used in an appropriate way. H1N1, yes, definitely oseltamivir has a definitive role. But in the current virus strain of H3N2, we are not sure that it will be working or not. So we have to be very cautious in prescribing the medications as per law. So moving on, Dr. Kripesh, as discussed with by Dr. Tridib, that prolonged cough after this current influenza or the virus infection is the most distressing symptoms. Sometimes the patient may present only with these symptoms. He will not have he will not tell you the preceding history. The history could be there. But that prolonged cough, what are the remedies there for that prolonged cough? Natural, herbal, allopathic? What is your take on that?
Yes, definitely. This prolonged cough is, I think, probably one of the important symptoms with which patients come to our OPD nowadays. They are having some flu type of symptom for a short period of time, which is maybe in the month of January, February, and till now in the March, they're still coughing. Another symptom has already gone. So in that case, I think we have to start step by step, like taking a steam inhalation or taking some antihistaminic in some group of patient for a prolonged period is going to helpful. Or if this doesn't help, then I think maybe inhaled corticosteroid useful in some refractory cases, or sometime in a very severe cases where we may need to use nebulizer or a short course of oral corticosteroid that will reduce the cough. But definitely we have to actually ask the patient to have patience, because this cough going to take some time, and just they have to wait for some time, because unnecessarily giving too much of medicine is actually not going to help them. It will take us some prolonged course, and majority of time it will going to resolve with the minimal interventions.
So rightly said, we have to use all the modality. Yes, inhaled corticosteroid may have some role. The other therapies or other things that is important that has to be applied. Vocal therapy is also important, because we have to counsel the patient that it may take some time to recover. So, Dr. Tridib, we were so much scared with the thromboembolic phenomena in COVID. Are we seeing any cases related to it in the current influenza infection like H3N2, something like that?
Let me be very frank, Ankit. I have not seen. I mean, there's very little scarce literature on this. When I got this question, I actually had to read up, and I found one or two studies which I will just share. One is one Dutch study which they have compared it with COVID, and they have found that there has been thrombotic episodes, but it is something around 3% compared to 11% of in COVID patients. These are all hospitalized patients. We are talking about indoor patients. And then some more, as it is, there is the tendency in all serious viral infections of having an increased thrombotic because of the involvement of the coagulation process, any serious viral infection, they tend to cause a little more chances of thrombosis. But I don't think there is, as of now, so much data to say that, oh, we should start doing D-dimer every now and then and send the patient for a CT pulmonary angio, which probably we were doing in COVID. So there has not been so much data to suggest that, but maybe it will come to know in future. Maybe the if patient is bedridden for a long time and there is an obese person, there could be more chances of that happening. But whether by itself, but definitely whatever 2-3 studies which I said, they have compared it with COVID specifically, H1. I'm not H3N2, I'm talking about H1N1. Yes. I have not found anything with H3N2. They have found that it is having something more than the common population, but significantly less than COVID. That's all I can tell.
Any different opinion of the House?
Yeah, I would like anybody else to.
Anyone has seen these kind of episodes in their population?
Sujeet or Tanushree, anybody?
Dr. Tanushree, Dr. Kripesh. I think we are on the same lines. Possibly, yes, we are not seeing these type of phenomena in particularly H3N2 or the H1N1 previously. So the most important crucial question now, Dr. Arjun. We talked about steroid a lot in the past pandemic or the COVID pandemic for 3 years. Where you place steroid in the management of these influenza virus, particularly H3N2, mild, moderate, severe? Please let us enlighten us with this particular thought, your thought.
A very important question, Ankit. We use steroids in influenza or not? So you also mentioned 3 scenarios, mild, moderate, and severe. So let's start with the mild and moderate. Absolutely no indication to give steroids whatsoever. So it's very clear about that. So the most controversial part is whether to treat severe influenza infections with steroids or not. Basically, when we talk about severe influenza infections, we talk about severe viral pneumonias and ARDS. So basically, there has been a thought that steroids could perhaps be added as co-adjuvants in the treatment so that they would reduce the morbidity and mortality. And this thought came from certain studies done in mice with H1N1 infected mice, in which they showed that steroids actually reduce the lung lesions and actually improve survival in mice. But unfortunately, the same cannot be extrapolated to human beings. So one of the first largest studies which has been done in this was in 2011, following the 2009 pandemic. And this was by the European Society of Intensive Care Medicine. They studied 220 PM. It's a multicentric study. 220 patients in various ICUs across the globe was studied. They found that 60% of these patients were actually on steroids, parenteral steroids, either oral or injectable steroids. But what they found was that it did not help at all. In fact, it did not reduce mortality. On the other hand, it actually increased the risk of nosocomial infections and hospital-acquired pneumonias when you treat severe influenza pneumonia with steroids. And similar results were found from studies across other countries as well, from Korea, from China, from France, from Canada, etc. But when we talk about the evidence, we always talk about the top of the evidence pyramid, that is the meta-analysis. The largest meta-analysis has been, in fact, has included more than 6,500 patients, and which was published about I think it's in the year 2017. And they had very, very important findings in the meta-analysis. Number one, if you give steroids to patients with severe pneumonia, the relative risk of death actually increases by 1.75 times. So actually it increases mortality. Number two, it does not reduce ICU stay. Number three, it does not reduce ventilator-free days. And more importantly, it increases the risk of developing nosocomial infections to the tune of 3 times higher risk of developing nosocomial pneumonia. So again, the answer to whether you should use steroids in severe influenza pneumonia, also the answer is a clear no. So across the spectrum, be it mild, moderate, or severe, steroids do not have any role, and they turn out to be counterproductive.
Any different view with Dr. Arjun regarding steroids? I know he has, with all these studies and relevant data, he has told that there is nearly no role of steroids in mild, moderate, severe disease. Any view in the House regarding that?
Yeah. So Ankit, just wanted to go back. Sorry, I lost connectivity for a little while. Just on before we go, the steroids part, the cough, I noticed from the question answer in the chat box, a lot of physicians, primary care also tuned in. Cough, when you evaluate in patients after flu influenza, you have to be a little careful. And so a few messages to these clinicians that we need to look at 3 or 4 common causes of cough, not just the sore throat and the postnasal drip, but also acid reflux and airway disease. So keep these 3 things in mind is what I would recommend. So you can have simple allergic rhinitis or postnasal drip causing your cough, which will just need an antihistamine, and if it's bad, a nasal steroid. You could have a lot of polypharmacy going on your patient by another doctor, and then actually the cause of the cough is just gastroesophageal reflux. And you could have bad airway disease or post-viral bronchitis, as we call it, or tracheobronchitis, which just needs a short course, anywhere between 5 to 10 days of inhaled steroid. So that's on the cough part. And that's one point I wanted to emphasize, because sometimes patients just get everything and then they're just so miserable. They don't know what has helped them, neither do they know what is harming them. As far as steroids are concerned, I agree with Arjun. Most of seasonal influenza will not need steroids and should not be given steroids. Probably, I think the only time I would consider systemic steroids is in a patient with organizing pneumonia. And these are patients with bad viral pneumonias who are running fever sometimes and are hypoxic in the ICU. And there, you're pretty much sure their counts are low. They have a low procalcitonin. Cultures are turning in negative. I think there's no harm in giving steroids to those patients, and they actually do better. But be careful before you give it.
Yes, I can agree with you, sir. I can see many questions, many clinicians are asking this particular questions of use of steroid in the influenza part. And that is very important, that the indication that you give, that is particularly the organizing pneumonia. Yes, we also find these set of patients who have persistent dyspnea and they are running out of symptoms. They can be offered steroids for certain duration of time. I totally agree with you, sir, in that. Otherwise, we should refrain from using steroid in these kind of viral illness. I would like to congratulate the House, as just messaged by Dr. Krishna, that we have 1,013 logins for this very important, interesting webinar that we are there. So congratulations to the whole CCI team for this wonderful initiative. So moving on, sir, again, Dr. Sujeet, sir, the question to you only, that in particularly severe diseases of H3N2, what are the complications we can anticipate? What are the common complications?
Yeah, so there's a lot of complications with viral infections that we need to be careful about. And I think sometimes the lack of training in general medicine reflects in our practices here. And coordinating with a good general physician, critical care physician, helps us pick up things like viral myocarditis, which can be very, very difficult sometimes to actually even suspect sometimes when patients develop complications. The other things are, of course, severe, myalgias and various systemic manifestations of a flu, viral gastritis. We have seen viral hemorrhagic gastritis, actually, where patients have had hematomesis sometimes. And everything has been attributed to the seasonal flu infecting. Arthritis is another very common complication, a systemic complication of flu. But I think we need to keep a watch out for these things. They often get strokes after a flu. And that's one of the reasons we actually tell our patients to vaccinate themselves, Ankit, because, their risk for myocardial infarction and stroke goes up. And I think that's when patients realize that they should take the flu vaccine. We often end up telling them, look, a lot of elderly patients in our hospital are admitted with stroke, unstable angina, and it's often been preceded by seasonal flu. With strain, we don't even want to know which strain sometimes, because we know that seasonal flu is bad. And But what we must also realize is that H3N2, if we actually type it as Tridib was saying, and we get to know it's H3N2, H3N2 has a higher mortality than H1N1, more hospitalizations, more sickness. And 2017-18 pandemic seasonal flu outbreak in Europe and North America was particularly severe, much more severe than the previous years. It never got to the headlines of the Indian press because we don't do flu surveillance like they do there. So I think that's the advantage of doing surveillance, getting the right strains, finding out which are the right strains, and tweaking your vaccines accordingly, which we'll come to discuss later. But I think that's important. When you know what's going on, it does help you, but it does make you more alert in terms of preventive aspects, for sure.
Totally agree with sir. Now we come over to the very important aspect, that is vaccination. We have seen this COVID pandemic. A lot have been talk about different kinds of vaccines. Some have some controversies also regarding to their later impact. So my question to Dr. Sujeet sir is that, sir, there are multiple questions related to it, and I'll request you to answer it one by one. First, what is the importance of vaccinations, particularly in these disease of H3N2? We know that there are two strains running out, that is the northern strain and the southern strain. So the which population has to be vaccinated with which strain? That is an important aspect. And do some individuals need both the vaccination, that is the northern strain or the southern strain, because the practice is something like that also? And do we have the same, lot of vaccines have been talked about the thromboembolic episode or when vaccine-induced thrombosis. Is the same there in influenza vaccine also? Any significant side effects? So there are around 4 questions in one.
Right. So I think, let me answer them all quickly so that we have enough time for other questions and other panelists as well, Ankit. Southern Hemisphere strain is the strain that is typed for India. So India comes under the region where Africa, Middle East, Southeast Asia, we all have more of the Southern Hemisphere strains which infect our population seasonally. As we've seen, our flu virus epidemics are usually less severe than what you see in the winter epidemics of Europe. And so we don't see it hitting the headlines every winter, there's a flu epidemic going on. But having said that, we should be vaccinating our population with the Southern Hemisphere strains which are out. The WHO in Geneva releases the strains every 6 months. And the vaccine manufacturers in India make the vaccines according to what information is released. We have the 23-24 seasonal influenza Southern Hemisphere strain already in the market in India. And we would tell our patients, to be honest, in Mumbai to get vaccinated in April, May, because our peak flu season is May to August in Mumbai and most coastal parts of the country. Whereas there are some people, I actually land up asking them, do you get flu more often in winter or in the monsoon summer? Most of them will say monsoon summer, but there are increasingly some people who say they get it in winter. And so in this type of a tropical climate that we have in India, anytime you vaccinate is good as long as they get 1 dose in. Then the question is, when do you take the next dose? You take the next dose ideally before the next flu season or 1 year later. Your question on whether there are side effects like thromboembolism with the vaccine, no. The seasonal flu vaccine, I have not seen that side effect. In fact, it's a very safe vaccine. We concomitantly give the pneumonia vaccine on the same day to the patients. It's one of the few things besides peak flow meters that I stock in the clinic because I want patients to take these home, especially elderly patients. You don't want them moving around, finding someone who's got the vaccine with the cold chain. A lot of our elderly patients prefer to just come when they review with us, just take the vaccine and go home. And now we'll have herpes zoster vaccine available in India as well in the next month or so. So that's 3 good adult vaccines that we can offer our patients and should be giving our patients. Your question and side effects, I would say there are very few. Egg allergy was a concern when these vaccines were made on egg cultures. And in fact, those vaccines were not really very good because the vaccine that was developed on the egg culture medium was not correlating with the circulating H3N2 virus. And so companies have moved away from egg-based cultures to cell cultures now. And so they're better vaccines now. And from split vaccines to subunit vaccines, which are much better. So the vaccines are improving. Their protection is about 40-50% against hospitalization. So not too bad. And the final thing was, of course, on whether you would give it twice or give both the northern and southern hemisphere. Occasionally, I've done it on occasion. And this is usually for these patients who are, traveling so much. They live in India, but they travel to Europe and North America extremely often. And so I tell them, okay, you can take the southern hemisphere in April, May in Mumbai, and take the northern hemisphere in October because you seem to be traveling across the northern hemisphere most of October. So I don't think there's harm in it. There's some anecdotal evidence of giving patients 2 vaccines in a year, but I wouldn't strongly recommend it right now, for sure.
So the current strain is covered H3N2 in this
Yes.
vaccination? Okay.
Yes. H3N2, H1N1, and then there's the B Victoria and B Yamamoto. But that B Yamamoto is almost out of circulation right now. But these are the 4 strains in the quadrivalent vaccine.
Dr. Tridib, want to say something?
I want to ask Sujeet. Sujeet, I was reading that there is something as high dose vaccine where you have that. So I would like your opinion. I mean, is it really indicated? And if so, which case? And is it available in India?
No, so I'm not aware of it being available, Tridib, but it's a very good question. And this is something that should be probably asked to a virologist. And I understand that virology is the most sought after branch in the United States now after the COVID pandemic. I think we are learning here, but there's some interesting data with the nasal vaccine. I don't know if you've read that, Tridib, where they actually used higher doses and got much better antibody titers in the blood, neutralizing antibodies. So higher dose nasal vaccines, the new nasal vaccines are supposed to be very effective against H3N2. And the earlier one was called Fluvic, I think, or something. And now there's a newer one available. And so we are going to see interesting news in this space. We got to keep up to date on this. And I think, we're organizing a chess meeting end of the year. And I really want a good talk in that Tridib on vaccines, because I think we are not updated enough on how these vaccines are developed and how they should be used and their efficacy, because we need to tell this to our patients. And our patients expect us to be up to date on vaccines, which I think very few of us are. And Ankit is right to put this question across, because I notice many respiratory physicians would just give what is available from their stockist or distributor. But I think we should look closely at that pack, SH, NH, as Ankit rightly said, the timing you're vaccinating. Some people who just give it because they stock it in their clinic, but then what's the point of the doctor? You might as well go to a pharmacist and get vaccinated, right?
So, Sujeet, suppose you have a suspected viral infection. Would you wait about 2 weeks to vaccinate?
Of course.
So I
wouldn't vaccinate at that time. At that time, I would wait, Tridib. And most certainly when you're going to vaccinate against, say, a more potent vaccine, for instance, herpes zoster, just to give you an example. I've taken it because of a friend could get it from London, but those vaccines can knock you out, and if you're going to have a flu and take that, you're 1 or 2 days, you just need to, not schedule any work when you take that kind of a vaccine.
Dr. Arjun, want to say something? Yes.
Yeah, Ankit, I just want to say 2 things. Number one is, as far as when to give the vaccine is concerned, in fact, we have an ICMR guidance for our country. It says that for most parts of the country, it should be given in April, May, before the monsoon sets in. But they have very specifically said for certain areas, they have mentioned Chennai, Vellore, which probably we can extrapolate to South India, and for the state of Jammu and Kashmir, where they say it is to be given in September, October. So that is one thing which I wanted to bring to the attention of this panel. The second thing is the question which Tridib Chatterji sir asked, the high potent vaccine. 0.75 ml vaccine is actually available in the United States, and they give it for all people more than 65 years of age. So they are given the high dose vaccine, because when the age goes up, the immunogenicity comes down. So they actually need a larger dose of the vaccine to get a good immunogenicity.
Okay.
That's very interesting, Ankit, actually, the point that Arjun made, because that's where you want a better neutralizing antibody titer. So again, the higher dose.
That is important. More vulnerable one. Yes, definitely. So we had a very good discussion on the vaccination part, because there is lots and lots of questions related to that in the general public mind also, and to the clinicians also. And by this discussion, maybe we could sort out most of their queries related to it. Moving forward, Dr. Arjun, what are the precautions that we look for preventing infection with H3N2? I know we learned a lot these 3 years, but we need to follow these. I'm not sure how much they are taken seriously now, but yes, they are important.
Of course, the most important thing to prevent H3N2 is the vaccination. As Sujeet has very rightly put it, it is the most important thing which will perhaps prevent influenza and also prevent developing the complications of the disease. But unfortunately, the knowledge, the attitude, and the willing to take the vaccine is extremely low in our country. In fact, we published a paper in Lung India about a couple of months back, looking into in a group of healthcare workers. We interviewed more than 1,300 healthcare workers, including doctors, and we found only less than 35% of them had actually taken the vaccine, although more than 90% of them really knew that it was available and it was very effective. So that is the most important thing. Secondly, whatever we have been applying when the COVID pandemic was there, social distancing, wearing the mask, using soap and water to clean your hands, using an alcohol-based sanitizer, all these are very, very important. And particularly those people who are vulnerable, who are immunocompromised elderly, we should ensure that they do not come in contact with a sick person and they do not go to crowded places. So these are the basic things that we can do. There has also been a school of thought whether you should be giving actually oseltamivir prophylaxis. We used to do it in the 2009 pandemic of influenza, but after that it has become so much of an endemic or epidemic, as you call it, so that we do not actually give prophylaxis. But although theoretically, there is an option to give prophylaxis in people who are at high risk, like immunocompromised people, if they have come in contact with a approved case, and they should be given the prophylaxis within 48 hours of them coming into contact. But in practice, we usually do not do this, but there is an option to do that for selected subgroup of patients. So these are the most important things: vaccination, all the other things, sanitization, social distancing, and all the things, and of course, a role for prophylaxis.
Definitely, I agree with you. I know it is a very difficult task, particularly when preceding years have gone with mask. And again, say patient that you have to apply mask now because some other outbreak is there. It is very difficult to convince our colleagues also and to the general population also. But yes, it remains a truth and it has to be followed, because this is the only way out to prevent it. Now, my next question is to Dr. Tanushree. Any dietary advice, particularly to prevent these type of infection?
Yes, sir. Surely I'll give a lot of dietary advice, but one thing I want to add to the previous discussion regarding vaccination. I was there at the panel of Pfizer just a month back, and we had a national level meeting on. They were basically had some doctors all over the country discussing on the point of limitation of why exactly we are lagging behind in vaccines. That was more concentrated on Prevnar, but we definitely discussed a lot on the other vaccines also. The major setbacks for vaccines is the not only the patient attitude, the cost pricing, but one major factor that we concluded upon was our colleagues in other specialities. As I have already mentioned, the vulnerable population among the patient having high risk was pregnant females, the cardiovascular patients, the renal patients, the oncology patient. So basically our counterparts in other branches are not giving heed to this vaccination to the level they should. And not only the chronic lung diseases are the one which are getting affected, it is the whole spectrum. So we need to increase awareness among our colleagues, counterparts, to vaccinate their particular group of patient also, so that the complication that Dr. Sujeet mentioned, there are a huge lot of complications that are happening up once the disease progresses to other level, so that are easily preventable it's such a sad reality that these things can be prevented in a particular patient, but we unfortunately are not able to target them. Not everyone reaches a pulmonologist, and they also do go to our fellow branches, and they should be more readily acceptable towards. As I have said, I'm one of the physicians. I'm a pulmonologist. I'm myself vaccinated, and I'm convincing Dr. Mayank to get vaccinated too. But sorry to say, he is not willing to, or I'll say they are just busy in their life. So I think that's important, that as a healthcare workers, we should get vaccinated. So coming on to my main question, dietary advice. So as both of us are pulmonologists, so the first incidence that we enter our home and we are having the viral symptoms, what I cook is a good, a good high protein meal, which is a non-veg, because what we feel is a high protein diet is a very good, something that we bet on, that yes, that definitely helps us recover. It's a good hydration, and having a good chunk of everything in your diet, a balanced diet. There's no secondary to this. The fact that exactly everything should be there in our diet, including vitamin C, has been provocated in proclaimed to be having a good use in COVID, similarly in influenza. And basically it's a respiratory illness, so doesn't really matter. The wholesome immunity of your body is what makes you fight through it. So basically a good diet, good rest, stress-free lifestyle, that is what is should be mainly aimed at.
I totally agree with you. We have to stick to our basics, and that is the most important part. Finally, Dr. Kripesh, an important thing is that what are the precautions we use to look, particularly post-influenza illness? We have seen lots in post-COVID. People have MI. You have been seeing all along in the news. They have strokes. Are these relevant in post-influenza illness also?
For post-influenza, the post-COVID, like these things are not so much relevant. But most of the people post-influenza, they will have a prolonged fatigue, basically tiredness and other things, and coughing. This going to persist for a long period. And in that case, the most importantly, they should maintain adequate diet and nutrition that already has been. So good diet and good nutrition, proper fluid intake is also important post-flu. And secondly, again, all the preventive measures that can again prevent recurrent infection or secondary infection, that has to be followed, like using a mask, or hence using a hand washing or hand properly, or like your cough etiquette. Whenever there is a coughing or sneezing, you properly cover your mouth and nose, even a post recovery period also. So
Okay. Thank you, Dr. Kripesh. Okay. Okay. So with this, I would also like to thank our audience for putting so much keen interest on the topic. Most of the questions we tried to answered it. Particularly, I would like to thank Dr. Prakash from Mumbai, Maharashtra. His answers was do's and don'ts. We have discussed a lot about it. Then we have Dr. Rajneesh from Uttar Pradesh, Lucknow, asking about the management of flu. This also we have discussed. We have Dr. Diresh from Delhi, who has been asking about the treatment of the long-standing post-viral cough, which we also discussed. Dr. M.A. Khan, yes, this is an important question. Do we need to worry? Is this flu could be serious, something like COVID? Your thoughts, sir, Dr. Sujeet, sir?
I don't think this will be as bad as COVID. I think we're much better geared for it. Though I'm not sure if the vaccine effectiveness in children. I'm a little concerned about children because, I have seen my pediatrician colleagues twiddle their thumbs literally in 2020. And now they've become very busy. So that's a little worrying for sure.
Yes.
That's a little worrying. That's one age group you need to be careful about. And also where you see climates very much like Europe, like for instance, the winter in Delhi is just like the winter in Europe sometimes, Those are areas which could be more vulnerable to bad outbreaks of H3N2. So we have to be careful and sensible, I think, in our practice. And I think we'll weather this. That's what I feel. We'll weather a lot. And, being overprotective doesn't help, as we've seen. Also letting your guard down doesn't help either. I do not expect this to become like a COVID pandemic for sure. I hope
yes.
not.
I think
I'm not an astrologer, but I hope not.
Yes, I think the House also has the same opinion on it, possibly.
Masking should be at least for certain people going to crowded area. You cannot go back to lockdowns again. It's not just possible. So, we have to do. I have taken my mask out from the cupboard yesterday. I'll be very frank about it. I had not used it. So, I think we should be a little careful. I told all the residents in my ICU that, what are you doing? Come on, everybody, all of you, mask yourself now. And I think that much precaution we should.
And especially I think I agree with Tridib. Sorry, I forgot to mention that. That's so important. Simple hand hygiene and masking. I have to confess, sometimes I would forget in the past to wash hands after you see each patient. Such a simple thing, but we often didn't do it, And how much of prevention that can occur. We know there's data on it, superb evidence on it, yet as clinicians, we forget to do it. So hand washing and masking, I agree. And for all of us who, and in the audience who go and do home visits and see patients with flu at home, they are sometimes the most infectious group, who are very sick and want to be seen at home, or who will land up in the hospital within 48 hours of their symptoms. That's where you definitely need to mask up. I agree.
Sujeet, one question on continuation of this.
Yes.
Like I have seen this patient yesterday and I proved it's H3N2.
Right.
So should I take up chemoprophylaxis of once a day for 10 days?
No, I don't think so, Tridib, unless you are
I don't have any comorbid, except I'm a little old, that's it.
No, but what will you take chemoprophylaxis with?
With oseltamivir 75 OD for 10 days.
There's been no data to show that it helps. So
it's given in literature. So it's for H1N1. I don't know where extraordinary take it here from.
For H1N1, elderly patient, yes, maybe. If you're concerned about getting it and you're traveling, you're going to be traveling, you want to be well. I think some people would be extra cautious. But again, it's an oral drug. I wish the inhaled zanamivir was available. And there's very little resistance to zanamivir because it's been hardly used.
Is it very expensive, that drug?
Zanamivir was about 500 rupees for a 5-day course.
Okay.
So it was expensive. As expensive as
oseltamivir. Recently, I just checked in the afternoon. It was like 200 bucks for a 5 mg capsule. So it's a 10 mg BD dose for 5 days.
Correct.
So the whole, the treatment coming out to be around in thousands. So
thousands now. So it's gone up the price.
Yeah, it's gone up.
So I totally agree. A very important question I would like to put from the audience to Dr. Manju Wadike from Maharashtra, Mumbai. Dr. Arjun, role of antibiotics in this flu illness?
Absolutely no, unless there is a secondary bacterial infection. Usually, there's no need to give it all, and we should not be giving antibiotics.
I think there has been certain guidelines also recently from the IMA also regarding the use of antibiotics which we use. Yes, I totally agree with you. Yes, definitely no role of antibiotics in this flu type illness. So I would like to thank the audience. One more questions like from Saibal Ghosh from West Bengal, antiviral like molnupiravir, any role in H3N2? I know we have very limited options available. Anyone?
It's a good drug for COVID, but not in H3N2. I don't think.
Absolutely, I would not bother.
Early use in COVID elderly patients, not young patients, I think it should be fine. The non, because even the male partner, if
Sujeet, Paxlovid has still come or not yet?
no, I have not been able to use it. I have no idea of it. There's someone asking a question here, Ankit, repeatedly on giving his father influenza and I think conjugate pneumococcal vaccine on the same day. I think we should just announce that you can do that for sure. You don't have to do them 4 weeks apart. And polysaccharide vaccine, you can vaccinate as well after a year, maybe. That should be fine. It's significantly immunocompromised even after a month.
So any side effects for the inhaled medicines particularly? Any precautions has to be taken for?
The only thing I know is that because it's a milligram dose, zanamivir is a milligram dose inhaled. Like any heavy duty milligram dose inhaled or nebulized preparation, you have to be worried about bronchospasm. And usually you're giving a bronchodilator, inhaled bronchodilator to these patients. So give them a bronchodilator as well in case they get cough and wheeze with the zanamivir. So that applies to tobramycin as well. High dose milligram nebulized can cause bronchospasm. That's the only side effect really.
So there has been question, is that vaccination safe in immunocompromised individual? Your take? Like a patient on cancer chemotherapy?
Absolutely safe.
Yes.
Absolutely.
Yes, we can go ahead with that.
Yeah.
Okay. So I think most of the questions we try to address of the audience in this part. My esteemed panelist, your final word and final take on this particular H3N2 new strain of old flu, starting with Dr. Sujeet sir.
So Ankit, I enjoyed being on this webinar. I think I learned a lot, and also reading actually to get up to date for this webinar was quite enlightening. I think the message is that, we are healthcare professionals here in this meeting. We're all in this together, and I think we should treat influenza sensibly. We need to give good, sensible advice to patients. And we need to empower primary care physicians to treat a lot of flu better so that they don't reach secondary and tertiary care. As respiratory physicians, we know we'll end up getting a lot of calls for flu, and it's just not what we are cut out to do in our hospitals. We have enough work in the hospitals and clinics with a lot of other complex lung stuff. So I think the important message is to keep this message going, just like you've done in CCI. Ensure that primary care physicians are empowered not just to understand the practical and the appropriate management in seasonal influenza, but also how to prevent it, vaccinate it, buy a little refrigerator, keep vaccines in their clinic, and vaccinate. I mean, if chemists are getting licensed now to vaccinate, I think a primary care physician should be ahead of that game.
Dr. Tridib sir, your take on it?
So basically, I would just sort of continue what Sujeet said. I don't think we need to panic. It's not likely to be, as he said, a pandemic of thing. I would not think it would be that way. We are much more geared. Sanitation, masking, wearing, washing hands, and not overreacting with excessive antibiotics. Vaccination 100%. You should be able to give the vaccine. It's available as a pre-filled syringe. I mean, you don't have to do anything. You just take it out and just push it in. I mean, maybe your wife can give it to you. So it's probably that's our, and being sensible, as Tanushree mentioned, normal diet. Don't go chasing only oranges and kiwis and like dengue. Dragon fruit khao to platelet count hi badega. I don't think we should go around chasing all that. Just have good nutrition, good sanitation. Wear the mask, especially people elder at 2 age groups, and the vaccination. And I think we should be okay. It would pass, and it would not be a pandemic. That's what I think. Thank you.
Okay, Dr. Tanushree, your take?
I agree with sir that there's nothing to panic about. It has come in the past, it won't go to that extremes because many of us are vaccinated and we have something to prevent it. So why not go for it? All this discussion will, be on a good note if we have sent this message to our audiences that we are discussing something major, which is very much preventable if you get vaccinated. And the vaccine is easily available and a very safe vaccine. You can just get it done blindly, nothing to think about as much you were thinking about for a COVID vaccine. So something that is so easily preventable should not be of anything of worry. And I think rest of the things are to be handled by the physicians and the pulmonologists. But from your point of view, you should go and talk to your nearest doctor and discuss the part of vaccination with them, whether you are eligible for it or not. And if you are, anyone in your family is, or your near and dear one is, you should be aware of that and you should get it done.
Dr. Kripesh. Dr. Kripesh? Yes.
Yes. So another excellent webinar from CCI. I'm grateful to Krishna sir and particularly. So the prevention is always better than cure. So we have to focus on preventive aspect. And as a physician, we must spread the message amongst the public that how we can prevent this flow. Because many times, until unless things get complicated, people don't focus on preventive measures. So again, we have to emphasize on all the preventive measures like hand hygiene or using a mask or all these things among everybody.
Okay, Dr. Arjun.
Yeah, as Sujeet said, number one is treat sensibly. Number two, no antibiotics. Number three, as we are talking about COVID appropriate behavior, now we have to talk about influenza appropriate behavior, like masking, sanitization, and more importantly, and perhaps the most important thing, increase the awareness of vaccination. Make sure that vaccination coverage becomes better, at least for all our chronic respiratory patients, ensure that we give them the flu shot.
I think very crisp and clear message by all our esteemed panelists. Entity emerging, possibly H3N2, we have seen in the past, but the important thing is that we need to be cautious. We need to look forward and we have to identify the signs and symptoms, consult with your clinicians, identify it, treat it, prevent it. That is very important. And the most important part is vaccination, so that you can boost your immunity up, so that you can be prevented from the severe form of the disease. I thank all my esteemed panelists, Dr. Sujeet Rajan, Dr. Tridib Chatterji, Dr. Kripesh Ranjan, Dr. Tanushree Gehlot, and Dr. P Arjun for making an excellent academic discussion. I would like to thank the family of CCI, the Chess Council of India, Dr. Krishna sir, Dr. Narayana sir, and Dr. Ashish, Dr. Anil, and the brain, Dr. Vijay, Dr. Atri, for making so wonderful contribution, thinking of those topics that are very relevant in the current scenario and arranging such a beautiful academic discussion so that our audience particularly get enlightened. In the last, I would like to thank our esteemed audience for their patience listening and putting so many queries. And I hope our esteemed panelist has answered most of the question. And I also thank the Cipla team for their assistance. Thank you all. Good night. Thank you very much.
Thank you. Thank you. Very good moderation. Thank you.
Good night, everyone.
Thank you.
Thank you.